Now let's go into detail of hemolytic disease of the newborn, which is caused by RH incompatibility of the blood of the mother and the child. So imagine a mother is RH negative, and the child, she is bearing. She has a child with a man who is RH positive, and the child, through Mendelian genetics, is going to be RH positive. So this fetus, a child, let's just say fetus, that sounds even better. So the child is RH positive. Now, what happens is if she is pregnant for the first time and she's got a baby which is RH positive, meaning it has the D antigen which the mother does not have. Now, antigens elicit immunological responses. So when this mother is having a baby over here in her womb, the baby's blood is separated from the maternal blood through a placental barrier over here, a placental barrier. And during the time of birth, during labor, when the baby is coming out, there will be damage to these membranes and the blood can mix. The baby's and the mother's blood tend to mix over there. So that's usually when the mother gets sensitized to these antigens which are present in the blood of the baby, in the fetal blood. And anyway, the baby's out by now for the first child. So he's safe most of the time. But the next child, next time she gets pregnant, and again it's an RH positive baby, then she has IgG antibodies. RH makes IgG antibodies. So IgG antibodies cross the placenta. They can easily cross the placenta. And because they cross the placenta, they start to destroy the baby's red cells. They cause hemolysis in large amounts in the baby and making him anemic and very low on oxygen for that reason, causing a whole bunch of problems for the baby. Now, what you should know is, can the first child also get hemolytic disease? Yes, there's a small chance. Imagine the mother has a bleeding problem where the placenta is damaged. There are conditions like abruptio placentae. This is where the placenta is damaged from some injury, from some impact, for example, and that can cause the blood to mix in the membranes. Or placenta previa. Placenta previa is a condition where the baby, where the placenta is not exactly placed properly in the uterus. So this is your uterus. The placenta is supposed to be mostly up here, but because of improper development, the placenta can be down in the lower in the uterus, where the baby can press on it, and that can actually cause some bleeding over there. So there might be a little bit of mixture of blood taking place when the placenta tends to tear that time in these types of conditions over here. Or if the mother, for example, got transfused with blood which was RH positive, so transfusion also can cause this. And then she goes along to have her first baby, then that baby will have a problem dealing with the antibodies that the mother has developed in these situations. And these antibodies cross the membrane and start destroying the baby's red cells. So here we have this one, these unfortunate system where the baby who is RH positive is going to start getting attacked by these IgG antibodies from the mother. Okay, remember, IgG crosses the placenta. I'm saying this again and again because the other antibodies, IgM, IgD, IgA, IgE, they do not cross the placenta, but IgG crosses the placenta. So, based on its severity, you have these different conditions over here. Now, if, we can start with the mild form, which is icterus, relatively mild form. Icterus gravis neonatorum. This is where you have a baby who is born and he has got jaundice, meaning yellowish discoloration of skin or mucous membranes. Jaundice, yellowish discoloration of skin and mucous membranes. Yellow skin and mucous membranes. Mucous membranes means like your oral cavity, for example. M-B-R-A-N-E-S. And this is caused due to increased bilirubin. Bilirubin is the breakdown product of red cells, of the hemoglobin. So when you have lots of dead red cells being destroyed, the hemoglobin is released from these red cells and is converted to bilirubin. And this extra bilirubin goes and sticks in the skin and mucous membranes. And actually, bilirubin tends to stick in the whites of your eyes, in the sclera. So the sclera has a lot of elastin. Elastin has bilirubin has a very high affinity to elastin, lots of affinity to elastin, and this causes the bilirubin to stick to the elastin. So the first thing that gets yellow is actually your sclera, or they're followed by the skin and mucous membranes. And you always want to see the sclera in the upper part of the sclera, which is the what you call the bulbar conjunctiva. NCTIV. It's not the conjunctiva, it's the sclera that becomes yellow, but that part. So you have to lift the eyelid and make the person look down. So make the person look down and retract his eyelid. This way you will see the color for real, if it's yellow or not. Why? Because some people who are exposed to a lot of dust, who work in construction or farming, they tend to get yellowish discoloration because of mud. That's called muddy sclera, which gets mistaken for jaundice many times. You have to check this in the light. Okay, you have to check this in which light? Sunlight. Never check this in indoor lighting, because indoor lighting tends to leave a yellowish hue when you look at someone's eyes with that. It plays tricks on you. So you should never, like when you're doing a clinical examination, never write that the person is jaundice positive in the middle of the night. You want to check this in the morning times, next to a window if possible. So then other than that, we have this so icterus gravis. Now jaundice or bilirubin excess never happens on the first day of life. It happens maybe in the second or third day of life in some people, which may be normal or may not be normal, but it never happens on the first day normally. It should never happen normally on the first day of life. Now these kids will be born with yellow eyes immediately on the first day of their birth, when they're just born, and that is not a good sign. That means there's always something pathological. So these kids are going to have congenital anemia of the newborn. Okay, it's a very mild form of bilirubin, but nothing serious has happened so far, so that's okay. That's not so bad. But then eventually, if there is too much of RBC destruction, then you have a very high increase in the bilirubin levels. So if there's really high increase in bilirubin levels, then you can have some problems after bilirubin levels. Then you can have some problems because this bilirubin can stick in the basal nuclei. Some people call it basal ganglia. Nuclei of the brain, which are responsible for movements of the in planning your movements. Okay, so this is going to cause some damage to the basal ganglia, and this condition is called kernicterus. Okay, and again, it's common in infants because bilirubin can cross the blood-brain barrier in babies, because their blood-brain barrier is not so strong. It's more permeable. So the blood-brain barrier, it's a barrier made by these tight junctions that exist in the cells around the blood vessels of the brain, which we'll speak about later. Okay, and because the baby's liver is not mature enough to deal with a lot of bilirubin, what would happen is a lot of the waste products we have are dealt with by the mother's liver itself. Okay, and that so when the baby is born and the umbilical cord is cut, the garbage he is producing has to be dealt with by the liver, which doesn't have enough time. I mean, it needs some time to activate all these enzymes which help in bilirubin metabolism. If the this high bilirubin can also cause a situation where there's severe anemia, and this baby is having very low hemoglobin, and because of this the body tries to desperately try and increase the RBC production. How so? The bone marrow of the baby, all the bone marrow is making red cells, but that's not enough, so it tries to expand its area of operations of production by using the liver, and mostly the liver over here for production. So remember how in erythropoiesis there are stages in the fetus: the mesenchyme of the yolk sac, that's the mesoblastic stage, is the first stage in the first trimester where blood is made. Then after that those cells shift to the liver and spleen, and that's called the hepatic stage. Following that, in the third trimester, pluripotent stem cells go to the bone marrow, that's the medullary stage. So what happens is, if all the bone marrow is filled up, those cells will be like, hey, we used to use the liver for as a site of production, why don't we go back to the liver? So this liver will have erythroblasts inside them, immature red cells, and many a times these babies die when they're born. Unfortunately, their heart gives up because of the severe anemia, and it's not getting enough oxygen, and so these poor kids die. And if you do their autopsy and you take a piece of their liver and look under the microscope, you will find these erythroblasts, these immature RBCs. This is called erythroblastosis fetalis. What do we call this? Erythroblastosis fetalis, and it's again due to very severe and very unfortunate thing where there's a lot of bilirubin. Okay, and if you see these people, especially if you see kernicterus, in kernicterus, the bilirubin has to be more than 20 milligrams per deciliter in level. Jaundice is when you have more than 2 milligrams, actually more, 2 milligrams per deciliter. Where's 2 milligrams and 20 milligrams? And actually your normal bilirubin level is less than 1 milligram per deciliter. Normal bilirubin is less than 1 milligram per deciliter, but you start getting yellow skin, mucous membranes, and eyes, which we call icterus, at 2 milligrams. So even if you are between the 1 to 2 milligram per deciliter range, you will not have jaundice or icterus, but you may still be called hyperbilirubinemia. You may have hyperbilirubinemia. High level, it's not normal of bilirubin, but it may not be visible clinically, so just be aware of that also. Then the worst form of the most severe form of hemolytic disease in the newborn is where it's called hydrops fetalis. So hydrops fetalis is a sad situation where it's called bag of waters. It's hydrops, fetalis. It's this bag of membranes and water, because the baby, if you see, unfortunately, the fetus, it's all it's dead. It's virtually dead, and severe anemia seen in these kids, and their body's swollen up because of the heart failure. Their body is completely swollen up, like in heart patients, and you get this bag of water over here. It's a very, very sad bag thing that comes out over there. And if you see in this X-ray or this scan of this, the edema makes their head look like because of the swelling, it looks like there's a halo around their head, so they call it the Buddha position, or because of that halo, like those religious paintings, they have that halo around all the saints and holy people. So you have the Buddha sign, Buddha position. All right, and POSITION position. And so you have hydrops fetalis. This is the worst form, and these kids hardly ever make it. If somebody's in kernicterus or even erythroblastosis, you can try exchange transfusion. exchange transfusion can be tried. What happens is, you know that umbilical cord which has those big vessels? Yeah, we have a way to take a little blood from the baby and inject clean new blood with normal levels of bilirubin. So by doing this exchange, what happens is you are able to get rid of the blood which has a lot of bilirubin, and you replace it with normal blood. And so you inject some blood, you take some out, you inject some more, so you're sort of removing that, clearing the blood slowly over there. So there's a three-way syringe that comes. So if this is the umbilical cord, you have this special syringe over there, and the syringe is a three-way syringe. It's got this special kind of a something that can rotate, where you can inject blood from one end into the cell, fresh blood, and then you rotate it and take blood out, the dirty blood out from the umbilical cord. Alright, so you use one of those umbilical veins, and you use that needle because the baby is newborn and that umbilical cord hasn't shriveled off yet, and so you use this kind of a three-way valve type of thing on the syringe. Okay, and again, that's more, and you'll learn more about this in pediatrics eventually. So what happens is you're able to inject new blood, and then you rotate this cock, and then you're able to suck blood back out, and then inject some more blood, suck some more blood out like this. And this helps in dealing with the erythroblastosis fetalis and the kernicterus types of cases. How can you prevent this condition? So one way is we give something called ROGAM, RHOGAM. It's antibodies against your RH, your anti-D immunoglobulin. So its dose is 300 micrograms of RH anti-D immunoglobulin that you give. Alright, so it is going to be given at 28 weeks of gestation, if you already know that the mother is RH negative from blood testing, and then after pregnancy. So this is 28 weeks of pregnancy, and then after that, within 72 hours postnatally. Postnatally means after birth. Within 72 hours you give ROGAM injections. Again, same dose of 300 micrograms will be given to these people intramuscularly.